Hi everyone. Today I'm going to talk about a very common condition which affects both groups, children and adults as well, otitis media. In this presentation, I will cover the diagnosis, management, treatment and complications. You will look the anatomy, the basics as well, and then we will also discuss very detailed clinical case which will help you in your own learning. So it's very important that you watch the full video. So if you are a keen learner. And yes, so let's start. I'm going to turn off my camera in the next upcoming slide so that you focus on the slide rather than on my face. So here we go. So let's see today's agenda one more time: understanding otitis media, clinical presentation, management, complication, and prevention as well. So let's take a look at the ear anatomy. This is the external ear, and this is the start of the middle ear. This is ear station 2. Here is the eardrum. Behind the eardrum, we have three bones: stapes, malleus, and incus. And you can see this yellow, it is the pus, which is actually caused by three commonest organisms which has the potential to cause otitis media: Moraxella catarrhalis, Streptococcus pneumoniae, and Haemophilus influenzae. Next. One more time, another picture, normal middle ear. You can see how beautifully everything is placed: eardrum, auditory bones, which we have discussed in our previous slide. And this one is the otitis media. You can see how the pus is actually accumulating in the middle ear, and which leads to bulging of the tympanic membrane. We have seen the anatomy of the middle ear. Let's take a look of definition and epidemiology. Acute otitis media is an infection of the middle ear which is marked by fluid accumulation and inflammation, which causes discomfort in the patient. It is very common in children, those particularly 6 months to 2 years, because of their low immunity as well and their high risk group. And it affects millions of population annually, pediatric population. Let's take a look of etiology and risk factors. So the factors could be viral and bacterial infections, exposure to tobacco smoke. So it is very important while you're taking pediatric history, you should ask about if anyone smoke in the family. And daycare attendance, because there's a high chance when your child goes to nursery, they are actually interacting with other children, and they are at high risk of carrying respiratory tract infection, which is one of the triggering factor for causing otitis media. And lack of breastfeeding, because breastfeeding is, I always put emphasis on breastfeeding, because it gives a good amount of immunity to your children. So lack of breastfeeding puts your child at risk of carrying this infection and leads to otitis media. So the pathophysiology. Acute otitis media often begins with the obstruction of the eustachian tube, which affect normal air function and pressure regulation. Obstruction leads to fluid buildup in the middle ear, and that's actually cause a breeding ground where bacteria and viruses can grow, and bacterial growth, and it leads to infection and further complications as well. So clinical presentation and diagnosis. When you examine a child, always we look for some signs and symptoms. So the patient complain of ear pain, irritability, fever, fluid drainage, difficulty in sleep and feeding as well. If the child is very young, like up to 2 years or less than 2 years, so the sign and symptoms might differ. There will be difficult sleeping, difficult feeding, irritability, and young children, they might touch their ear again and again, and that actually allow you to think that there's a possibility of otitis media or any ear infection in the child. What is the diagnostic criteria? So there's a middle ear effusion, tympanic membrane inflammation, and associated symptoms, systemic symptoms like pain, fever, irritability, that actually help us to make a confirmed diagnosis. What other things you can think of if a child is complaining of ear pain? It could be otitis media with effusion, it could be external ear infection, otitis externa, or it may be referred pain from dental issues. So as a clinician, it is important that we do the examination appropriately to find the right diagnosis. Next. Let us start with a clinical case. Are you ready? Yeah. So, 11-year-old boy attends the ED department. He presented with a 4-day history of right-sided earache associated with fever and discharge from his ear. It was not possible to view the tympanic membrane, and all the vitals are normal. You can see the picture, the ear is red and there is a discharge otoria from the child's ear. So what do you think? Is it otitis externa or otitis media? Next. There are some features that help you to find whether the patient is suffering from otitis externa or otitis media. Ear pain is present in both conditions, whether otitis externa or media. Discharge is scanty in externa, but it is moderate or severe if a patient is having otitis media. Hearing is affected early in case of otitis media and lower onset in otitis externa. There's a history of upper respiratory tract infection in media but not in externa. Tender ear canal, yes, in otitis externa it is pretty tender, and in otitis media, no. Canal soiling in otitis externa, yes, there is a soiling, but in media, no. Eardrum. Eardrum can be difficult to visualize if a patient is having otitis externa. When you see otitis media, so the eardrum is red, bulging, or sometimes perforation can also occur. Intracranial complications is not associated with otitis externa, but they are present in otitis media. Why I'm discussing this? Because at this point, you should know that you are dealing with media or externa, because if you ignore the case, it can turn up into severe complication, which we will discuss later. So what are the management and treatment strategies generally and as per our case, which I'm discussing with you? So antibiotic therapy, it is the main aim to treat severe otitis media. Generally, we give amoxicillin to treat it, and there's another way is a watchful waiting. In mild cases, we can choose this way, a watchful waiting approach before initiating any antibiotic therapy. However, as our case is concerned, this patient has mild otitis media. So in children of this age, indication for treatment with antibiotics include child symptoms not improving after 3 days. As in our case, the child presented after 3 to 4 day history. So we decided to start amoxicillin for 5 days, regular analgesia, and we send the patient with written and verbal safety netting. Why amoxicillin? In this case, we choose amoxicillin. The reason that this antibiotic has a narrow spectrum and it covers all three organisms, Streptococcus pneumoniae, Haemophilus influenzae, and Moraxilla catarrhalis. Because patient was complaining of pain, so we give appropriate analgesia. It could be paracetamol or ibuprofen, depending on the history. If patient is having asthma, so we actually choose different options. Next. What is the watchful waiting approach? The watchful approach involves close monitoring of the patient with mild symptoms without treatment. Time frame for monitoring 48 to 72 hours before deciding on any appropriate options. Criteria for antibiotic therapy. So antibiotic therapy is initiated only if symptom worsens or do not improve during the monitoring period. In our case, we have already started the antibiotic treatment because the child presented to ED with 3-day history. So this phase of 48 to 72 hours has already been passed. So we directly started amoxicillin for 5 days. Next. What complication this patient can have? Let's see. Generally, potential complications include hearing loss, which can affect communication, quality of life, tympanic membrane perforation, or this infection can spread to mastoid bone or sinuses. Complication of mastoiditis, meningitis, venous sinus thrombosis, as you can see in this picture, and CNS collection, cerebral abscess. So let's continue our clinical case. What we have done, we have given antibiotics, we have given regular analgesia and safety netting, written and verbal. Now, after 48 hours later, the same child reattended the emergency with the following: fever, protrusion of the right ear, as you can see in the picture, fluctuant periauricular swelling, severe headache within 24 hours, even with regular pain relief. So what do you think? It could be CNS complication. In other case, CNS complication can occur in the absence of mastoiditis. The patient usually presents with severe headache and drowsiness. 1 week after initial air examination normal, but they have developed CNS complication. Such sort of patient, they need urgent neuroimaging because sometimes it happens as well. We do the blood test, and blood tests are as follow. Hemoglobin is 135, white blood cell count 21.3, platelets 380, and CRP is extremely high, 146. What is your next step? We go for urgent neurootological imaging where we visualize brain and petrous bone. Now MRI has been done and the results are here. Petrous bone shows right periosteal abscess of the right mastoid bone and right-sided venous sinus thrombosis. You can see the thin arrows and thick arrows. Thin arrow points to a small epidural abscess and thick arrow points to thrombosis in the sigmoid sinus. After doing MRI scan, we transfer the patient to theater urgently. Drainage of right mastoid done, insertion of Grommet, and anticoagulation started. After that, the child was treated with 4 weeks of antibiotic post-drainage. Ophthalmology was arranged with the following result: normal visual fields and acuity, normal color vision, there is no papilledema. PICC line was inserted because the duration of giving the antibiotic was prolonged, and the child was ambulated on 6th day of admission. Follow-up care and prevention is important, and so that we can monitor the patient. In our case, the child had MRI at 3 months, which shows recanalization of venous sinus, 6-month course of anticoagulation, and no long-term neurological consequences, which is pretty good. When you can refer your patient. So if patient is having recurrent acute otitis media, complications of acute otitis media, or there is a failure of standard treatment, so these are the 3 points which make you to refer your patients to the appropriate department. Prevention and public health consideration. As vaccination strategies, it is important for the families to vaccinate their children, for example, pneumococcal vaccination, influenza vaccination, and they should know the impact on acute otitis media incidence. So effective vaccination strategies can significantly lower the incidence of acute otitis media and in pediatric population. So it is very important that you guide and teach the families, because sometimes they are not willing to vaccinate their children because of the side effects. So it's our duty as a clinician to guide them for vaccination. Preventive measures. We should promote breastfeeding program for families and new moms, reduce tobacco exposure, because minimizing exposure to tobacco smoke is crucial in preventing health issues like otitis media in children, and hand hygiene promotion as well, so that young children, they can be prevented with these measures. Right, so public health impact and education. It is extremely important that we empower families so that they can take appropriate measure to reduce the risk of acute otitis media in young children. And so there are some preventive strategies which we have discussed: hand hygiene, promoting breastfeeding, and reducing smoke. And this awareness is crucial for families to understand the condition and its impact. And it is not always simple ear pain. It can lead to further drastic complication to your child. So it is important, like if condition is not getting better in 2 days, and if a fever is not reducing, if your medicine are not working, don't keep your children at home. I hope you found this lecture useful, and it will help you to deal all cases of otitis media with confidence. Thank you so much. Have a lovely day.